transplantation is important in terms of the newer drugs, as I said, and I'm pretty sure some of you will be rotating in cancer, in some of the medical departments where you come across people who have been transplanted an organ. So the main objectives that I want you to know, of course, a little bit of an overlap of what we discussed earlier, because for transplantation, I would expect that you know what is MSC. And also keep in mind, one of the transplantation we did was ABO transplant that we normally do as a blood lab. So that's also because blood is a tissue. So we give this matched blood that again is a transplant, technically is a transplant. Then bone marrow is a transplant. So I want you to know the different types of grafts, and also what do we mean by rejection of graft. If say graft get rejected, so we classify that into acute, hyperacute, chronic, and so on and so forth. And sometimes the body doesn't take that graft, and there's a disease process, as I said probably yesterday, graft versus host, GVH disease. And then finally, as a part of this course, of course, I would want you to understand what is going wrong. What is the immunology of transplantation? So I'm more interested in immunology as compared to drugs that we normally use for transplantation, but I will also touch upon some of the drugs, of course, because that will give you a clinical perspective of what we need to know. Okay, and as I said in the MSc lecture, that the commonest transplant done all over the world, of course, is cornea, and it does not evoke a reaction. As a rule, body should reject a non-self thing. So whatever is you, but if you want to add anything in terms of tissue like cornea, and we also gave a reason that there were some highly protected sites which have immune privilege. And there are many reasons for that. Some of the immunologists think because there's no blood supply of cornea, there's no lymphatic drainage of cornea, so there's no way the antibodies can go there, there's no way T cells can go, so there would not be an immune response. And there are many other reasons for that, but that gives you an idea as a classical or the most successful transplant that we have. And this is what I was mentioning, that I just got it like maybe an hour ago from the Organ Procurement and Transplantation Network. And they are talking about the statistics. That's what epidemiology means. Those of you who are going to do the slides for epidemiology, that's what epidemiology means. What's the incidence? What is the rate? And all these are maintained. So you can see from here, the US transplants have exceeded 30,000 for the first time. So there was like 2014 to 2015, 5% increase. And this 30,000 or 31,000 organ transplants were done in 24. So it's quite a high population. So you will see these patients in the hospital. You'll have to manage them as physicians and pharmacists. You pretty much have to know what is going on in that. Okay, so there is a rapid increase in the transplants that we are doing over years. Now, if you compare the data, I think it's from 2003 all the way to 2015. So you will see that they recover these organs from deceased people who donate their organs. So you will see in terms of supply and demand. So this is the patients who are waiting for transplant. So as far as patients waiting is concerned, there are more than 120,000 patients, and they have the registry in US. You need to transplant. But as far as the organs are concerned, they're pretty much stable. So supply and demand do not match. So they are still people are declining to donate their organs, and the need for the organ is rising, as you can see from this graph. And if you look at, I mean, this is just a summary of what was there in the previous slide, and you can see over here, this is like 121,478 people need a life-saving organ transplant. So we're talking about life-saving, you're not talking about cornea. Okay, and then this is the amount of registry that they have. 13,708 donors for the US out of a population of about like 300 million population. So we have a big problem here. Anyway, now some of the things that you have to ask yourself just to kind of have this understanding that what is transplantation and what is the immunology of transplantation. And one of the things that I would want you to think is that, of course, you can think all food is antigen, right? The drinks, the food, the dress you wear, you know, the things you apply on the skin, everything is taken as an antigen, non-self. Sometimes we mount a response, sometimes we don't mount a response, right? So we can kind of play around with that. But one of the questions which has bothered immunologists for ages, and that we are still studying it, we call it reproductive immunology. And the question is that, why is it that the mother would not reject a fetus? So we know that it's not a matched donor. Nobody's going to go and get, hey, you know, as a part of dating, mating, whatever that is, you're going to go match. So matching programs with all those sites don't match your MSc unless you're going to marry an immunologist. He may ask or she may ask for that matching. But of course, if you have a problem in terms of infertility, those pairs who are not able to conceive, they would definitely seek that. So that's where immune system will come. If they have a successful intercourse for 2 years and unable to conceive, the chances are we need to investigate. That's where immune system plays a role. But just to not to confuse you, the anti-HLA antibodies can arise possibly in pregnancy because this is a foreign gene inserted to mother, by all means, because half the gene is coming from the father, half from the mother. She wouldn't reject her own, but definitely she's going to reject the father's. But it does not normally happen, right? So that's a question that we always struggle with. I'm not going to teach you much, but just a food for the thought that you can see from here. Genetically, half the genes from the father and half the genes from the mother. But still, pregnancy goes on. There are many different things, very different concepts that we have, but all I want you to think in terms of the pregnancy is that it is in a very protected place. It's a placenta. Though it is technically a part of the mother, but you know, in the other word, is a potential space in the uterus. So everything is separated. So placenta has those special cells. Those circulation goes, but as we talked about in antibodies, not all the antibodies will be able to pass. Okay, and we talked about these Fc receptors on placenta and many other receptors that will stop something happening for protection of the babies. Okay, so that's an important thing, especially even if it's going to be a mismatch, which surely is a definite mismatch at MSc level fetus. But still, most of the time, the mothers would not reject it. Okay, so that's a subject of study. I mean, just have to quiz yourself based upon your information that you have learned so far in immunology. You just ask yourself, hey, why is it? So placenta is major thing in terms of a barrier that we have because it has a filter. It's going to filter anti-MSc antibodies because you know that not all antibodies can pass through that. So that's one protective thing. The other important thing is that as far as, I don't want to teach you embryology, but if you look at embryology, you will see that of all the layers that are in contact with the fetal tissue, and maternal blood, there is a very specialized cell we call trophoblast. And that trophoblast either expresses very weak or no MHC. And you know, as immunology students, that you have to have an MHC to process an antigen, right? That's why we give gamma interferon, that we give cytokines. We want it to be upregulated. For good reason, the mothers are tolerant to the fetuses in initial months, especially, because the trophoblast would not allow expression of MSC. So that's, but this is only a very small incident. There are many other factors that are there, and we are making that as a model to learn to use that protective mechanism to transplant an organ which may not have a success rate. So we are learning from reproductive immunology. And if you even go back, even for when we investigate people for infertility, sometime, you know, the sperm would not fertilize the ovum. So the sperm would have some kind of an antigen which is going to provoke for the females to make antibodies against sperms. So that again will be something they want to investigate if such a thing happens in infertility, because that again is the same system, right? Because cells being inserted into a female body, and if they are going to be presented, then again antibodies will form and we have problems, so on and so forth. Anyway, there are many other things. One of the other things that you can think is that mothers produce progesterone, which is a hormone which is immunosuppressive. Placenta expresses Fas ligand, and you can see what's the importance of Fas ligand over here. That again is protective, but sometimes things go wrong where you have abortion. So one of the abortions is that then the maternal immune response kills the baby. So that's why we have abortions and so on and so forth. And in terms of the mechanisms that are there. There are many other good things for transplantation and things of this technology. And the one thing, I just want to give you a flavor of that, forensic evidence of, you can see over here, this is an allele ladder over here. They pick up a DNA from a crime scene, which is over here, and then they have suspects 1, 2, 3, 4, D. And you can pretty much see which is going to fit in with, they found this allele over here at the crime scene, and it perfectly fits this particular person when they ask for, you know, the tissues. Usually is a swab from the saliva or blood, or in rape cases, it could be a semen. So there are many things, but they do this matching. And this kind of is 99.99% correct. So if you go to that level of a gene, so you can see it's a very important forensic evidence that they normally is used in the court. Anyway, we normally use blood transfusions, and you pretty much know that is the RBC ABO system. And this is successful for most time, but we don't count as when we calculate the incidence and ratios for transplants. The one that show you 30,000, of course, doesn't mean this one. We're talking about the major organs, right? But this is one of the success stories. Graft rejection is also important, because what normally happens is that I'm pretty sure that statistic also doesn't include burn patients, because in burn patients, what they normally do is that if the skin area is burned, they will remove that damaged area, and then they will take your own skin from a different part of your body and put it on top of that and suture it. So that's a normal procedure that they normally do, skin graft. We call it skin graft. But sometimes it gets rejected. You cannot kind of go from one person to another. But by all means, rejection is based upon either CMI or an antibody mediated. So that's what we call histoincompatibility, and we call the graft is rejected. Okay? So there were very different experiments. And again, I did ask this question, and I was amazed some of you are still confused. But it was there in MSc. I'm going to talk about again donor and recipient. We do all these experiments, of course, in animals. We don't want to do on humans. So if they are going to transplant a tissue from MSCA, right? Let me go one step back. If you just want to take in burn patient your own tissue on your own skin, we call autograft. There's no point of rejection. The only rejection that could happen over here will be infection, if the graft gets infected. Okay, other than that should not be there. We call it autograft. And then we have MSC from MSCA. We call isograft or syngraft. Again, they're like, if you want to go from an MSCA to MSCB, which is not matched, you can see it's not matched, though it's an allograft within the same species, but it's going to be rejected. Okay, but if you go across the species, for example, you want to take a mice and put it in a rabbit, which of course will have a different MSC altogether, we call it xenograft. Again, it will be rejected. So these two will be rejected. We want to find out how and why and how can we possibly fix it, because if the demand is so high, only a couple of thousand people are willing to donate their organs, 120,000 people are waiting over there, and they're going to die if you don't give them the organ. So what is the solution? The solution is that they are talking about stem cell growing this particular organ, but it's going to take a while. So I would rather have the tissues from animals to be transplanted into humans. And I gave you an example the other day that they wanted to use pig, and first wanted to try that on baboon, on monkey. And what was the mechanism of rejection? Does anybody remember what I said? Why would, if you take a heart from a pig and want to insert in a monkey, and the monkey would reject it, so that rejection is based upon which component of immune system? I told you in the class at that time, exactly when I narrated the story, if you were paying attention. Yeah. Louder. So say it again. No, I was very specific. It's a general. You're using a very general term. I was very specific. Okay, so it doesn't mean if you look at me, open your eye, you're still not with me. Say it again. No. So bad for me that I'm unable to communicate. I thought people in front of me. I said compliment. This was when I was teaching you compliment. That's where I gave you the story. I wanted to make sure that you understand the rejection was because of complement proteins. So complement is a real killer. That's what the problem we are having today for the transplant is complement. And then probably you thought, who's going to care for those difficult lectures and what C1, C3P? You leave it on choice. That's what people used to say. But that's important, right? So complement is important in terms of transplantation. Again, donor and recipient, we already talked about that. This is something that you be aware that I'm going to definitely ask you one question from there. I want you to at least know when they talk of an autograft, an isograft, and L, what do they mean? And that's pretty a jargon that you will see. Oh my goodness, I don't want that. Remind me later. Okay. They want, you see, I'm teaching transplant, and the system wants to transplant into my PowerPoint presentation. But he's asking for permission. That's why you need to have a permission to transplant. You cannot do it. So I said, okay, skip it. Okay. Now, the important thing that you need to know is that what is the immunological basis of rejection? If it's successful, we don't care. Good for you. But if it is rejected, so you can see from here, from the top, that let's see over here. So there's a tissue, there's a blood vessel, and you want to insert this piece of graft. So you want to cover the skin. Let's say skin graft. So a bigger area gets burned. You remove the skin. Usually you take it from the upper thigh, slice the skin of the thigh, and then take it up like a cloth and put it over there. Hopefully that other wound will heal. That's what normally happens. But let's take it in a smaller area. So the moment you put over here Again, there is inflammation over here, and then many things could happen. For example, one of the success story can happen is that because you want this to be a part of this tissue, so you need all those cells for inflammation, for repair. It's a pathophysiology we already discussed. I'm not going to discuss again. What are the cells which are going to come over here and fix the tissue? But I can quiz you. What is the most important cell you want to come and fix the tissue so that this becomes a part of the original tissue? No. What's the most important? And I actually say this in my slide very clearly. Fibroblast. I said, because you need a cell that produces all this fibrous tissue. I said, it's like a tailor. Okay? And just also keep in mind that I think they're going to institute a mile marker exam every year, probably from your class. So you'll be tested with all those subjects you already passed even. So this, it's there. I don't know. Did you take it last year? Or maybe they're going to have it this year. So mile marker will be that I still have to write some question to tell them because they want to keep you update from previous information. But some of the things like I'm just sharing with you is important, right? And many a time, this is a question that you ask, okay? So you have blood vessels over here, they blink all this thing, and there's a proper healing, you got full acceptance, good for you. Everything normal, okay? Now, the other thing is that you put a tissue, and the blood vessels are already there, and then the blood vessels will allow the cells to pass through, right? And these cells will be, of course, neutrophils will be there as inflammation, other cells will be there, other cells of acute inflammation, and the cells of immune system will also go. So B cell will go, T cell will go, they look at the tissue, and then there is going to be a crime scene, so to speak, right? And then at the end, they decide, kill it. So there'll be full rejection. So you can see from here, they will reject it. So once they reject it, again, they are going to put the fast ligand over here. They're going to kill it by inflammation. And most of the time, it's going to get killed by necrosis and not apoptosis. Because the reason is that you will see that on the top over here, this kind of activity is where there's a lot of debris and a lot of dead material. Apoptosis is basically a clean, organized demolition with no inflammation. But this shows you there's inflammation, so obviously it's necrosis. Thirdly, you can see over here, sometime it may happen that we don't have a full acceptance and we don't have a full rejection, so we are struggling, right? That is where we talk of in terms of a acute rejection, for example, if this was an acute rejection, or we talk of it like a rejection over time. Okay, so I'm going to discuss that in a little while, but just keep in mind whatever we taught you in terms of acute inflammation, chronic inflammation, cells of acute inflammation, cells of chronic inflammation, repair. So this is where all these things will come into place in terms of your understanding why a graft is rejected. Now, in this case, what's happening is, why is it taking longer time? Because the immune system has to organize, and it has to mount a response, which according to our definition is delayed type hypersensitivity reaction. And as the word suggests, delayed type. So the chances are the CD4 and CD8 T cells come. They don't go for the kill straight away. They take time. They want to make sure they do a good job, right? That's why it takes a while. So this kind of rejection that you see is more of an immune type rejection, and it takes a while. But if you were to take a biopsy, for example, over here, you will see plenty of CD4 T cells and CD8 T cells and many other cells which are there, right? But again, this kind of the cellular infiltrate that you see will have, again, if I was to take a section over here, I will see mostly neutrophils. If I was to take a section over here or here, I'll see mostly fibroblasts. If I was to take a section over here to find out in biopsy, I would see lymphocytes as well. Sorry? Yeah, we are not interested in pus because we are interested in immune response. Whether it is pus or not doesn't matter because pus shows infection. Right now, I'm not talking about infection. Pus can only come if there is infection. We are now doing a classical, simple immune rejection where we expect there should be no pus. Because if the pus comes, it's going to complicate the matter. That makes sense? So, clean. We're talking about clean. You're talking about University of Chicago. They shouldn't have, infection in the transplants. If they do have infection, that's a serious problem. There's going to be a big litigation for them that they are not doing it clean. Usually, surgeries are clean. If there is infection for some reason, diabetic patient, we have a very complicated problem. But we want to teach you as a part of transplantation. We're just giving you a perfect scenario. That makes sense? So immunological basis, that's what I'm trying to find of an allograft rejection. If you take the biopsy, you should see lymphocytes, monocytes, CD4, CD8. Then we want to do experiment. We want to see, okay, if the T cells are the major player that cause rejection, so immediately you will think, I want to prove that. So I'll take a mice, knock out T cell, and do the allograft, and guess what? What happens? If I was to take a mice, knock out all the T cell, and then do the graft, what will happen to the graft? Would not reject, because you took the T cell off. T cells were killing it. Does that make sense? So, but you cannot do it to human beings, but it proves the point, right? What we do in human being is that we know the immunity is to be blamed. You got too much of immune system, you got delayed type hypersensitivity. So you would rather give immunosuppressive drug. So that will give a chance. If, for example, you need to transplant a kidney and you're not sure, you didn't get the right matched donor, you give a kidney transplant and you want to stop the immune response to occur. So you will give immunosuppressive drugs. So what will happen is the rejection will be delayed. Will be delayed. Okay, so you give a little bit more life to that. Or, let's hope, get stopped, but technically not. So we divide this kind of rejection clinically into 3 types: hyperacute, as the name suggests, pretty quick, acute, and chronic. And that's what I'm going to spend a couple of minutes on that. And hyperacute means it occurs within minutes and hours. The cause is preformed antibodies. So this means this particular patient had already antibodies existing prior to transplant. So that's an antibody problem. The whole process is the antibodies will come, activate the complement, and when the complement gets activated, you initiate clotting mechanism. So you increase the clotting mechanism, platelets will come, and then they will cause the swelling, inflammation, thrombosis, and then there will be endothelial injury and necrosis. So this is we call a sequelae of, we call it pathogenesis. I think in one of your individual projects also it says pathogenesis. So pathogenesis most of the time is immune pathogenesis. How would Staphylococcus aureus cause tissue death? So you have to talk about all those steps, 1, 2, 3, 4, 5, 6. So and you need to know the cause. In this case, you know that there are preformed antibodies, activate the complement, platelets come, they deposit over there, and then there's going to be swelling and edema. How would complement cause, what component of complement will cause inflammation? Aflatoxins, good. Aflatoxins, correct. What is it? What is the technical term for that? If I was to ask you C3 and, you remember the breakdowns of the proteins, of complement protein? I say they're going to break into a smaller portion A and a bigger portion B binding. Which portion are we talking about right now? A, correct. B is for the binding. A. So A is pro-inflammatory. So that's where we need to stop. So if you want to help this patient, if you want to increase the chances of transplantation, you have to stop C3A. That makes sense? So complement is important. In a typical situation, what normally happens is that you can see that you want to give a graft for the kidney. You want a kidney graft, right? And then you will see that there are existing antibodies over here. And these antibodies will attach to the capillaries in this organ. You can see these antibodies coming over here. And these antibodies have a site for the complement. They are going to initiate the complement, and the complement will initiate a inflammatory response. And when the inflammatory response is initiated, all the cells of inflammation will come. And the other problem will be that you need clotting mechanism to stop bleeding, so that if there is an injury to the vessel, you need it to block. That's why you want a platelet. Platelets are there to help you to block the hole. In this case, you call platelets, but platelets are not blocking anything, but they are causing a problem because they are forming a obstruction over here. So they are forming a blockade, a vascular blockade. Okay. So if you get a vascular blockade, what will happen to the kidney? Supply of blood. So what will happen in pathophysiology of the kidney? What is the term that you will use? Before necrosis, yeah. Ischemia, very good. Ischemia. Very good. Ischemia, that's what we say, ischemia. Ischemia is a technical term that you use before something happens, because you're dividing a tissue of an oxygen leading to ischemia. Good. Now that was hyperacute rejection. In this case, is an acute rejection. If I say this occurs in non-sensitized recipient, what do I mean by that? You spent 2 lectures on sensitization in allergy. If I was to tell you, hey, this patient, I'm conducting it around, I say first year, second year pharmacy student from CSU, they've already completed immunology. Hey, this note says this is a non-sensitized patient. What does it mean? Sorry?
The patient does not respond. This does not feel what they are suffering, maybe
energy?
Antigen, not exposed.
Not exposed to an antigen. Okay, anybody else? Somebody was saying something I overheard. Okay. Okay, remember that sensitization basically means that you're exposed to that particular. If you compare that to the previous one, where I say preformed antibodies. So preformed antibodies can only happen if a particular antigen is right in a way. The antigen was given to you and your immune system saw that. Right? In this case, is say non-sensitized. This means this patient does not have preformed antibody. That's what it means. No. We don't call it naive. Because when we talk of allergy, we talk of sensitization or non-sensitization. Whether your system has seen that antigen, and many a time we say the term that we use in allergy, which I thought I taught you. If I ask you right now, what is desensitization? Ben?
It wouldn't be an allergic response?
Well, that's a vague answer. You want to be specific in the immune system. Desensitization. Anybody else? What we, yeah.
Patient exposed to it, but does not respond.
No, desensitization is a treatment plan where we give exposure to the same antigen that cause an allergy over a period of time slowly, so that you build immune response not to react to it. That's why many times you go over there and say, you know, I've got allergy to such and such thing, but I cannot avoid it. It's like, I'm living in Chicago. I can't go from Chicago. It has a very high pollen. What do I do? So we desensitize your system slowly with the pollen that we have by giving you very little doses of that thing, so you kind of build up, you don't build up that acute response. Okay, so that was something that we said, yeah. No, don't take the words in English. Right? You take the words of a definition in immunology. Sensitization will mean that your system has seen in that antigen. Okay, and non-sensitized patient will mean that that particular antigen, which causes rejection, acute, your system has not seen it. As compared to, so this term has to be compared with the previous one where there were preformed antibodies. You will not understand non-sensitized if you don't understand the hyperacute, because it is comparing these two. Of course, we are dividing hyperacute and acute separately. The reason is because one is being exposed to that, the other is not. Okay, that makes sense? All right. I mean, I can tell it does not, but you may have to do a little bit more reading. So what happens is that this kind of reaction can occur because that was pretty fast. Antibodies are already there. They see the antigen, go and kill. But in this case, since they have not seen that particular antigen, so it will still occur, right? But it will come over time, right? So what we do is we give you immunosuppression not to let it happen, but again, the moment we stop immunosuppression, then it can occur. But why do we need to stop immunosuppression? Just guess. Why do we need to stop immunosuppression? Do we want to keep you on immunosuppression forever? No. Why? Infection. Very good. Of course, infection. Because you are taking away the primary function of your immune system to protect you. So what will happen is if you give you steroids, those of you or your family member, they have asthma, and when they give them steroid, they also give them antibiotics at the same time, because you are going to be prone to infections. Okay? Now this acute is because of T cell, and the T cell directly recognizes alloantigen expressed by the donor cell. And that most of the time occurs in patients who have received mismatched tissue and then insufficient immunosuppression tissue. So this is a typical scenario where you want to save a person, you just go for an organ, you mismatch the organ, there's going to be immune response, the T cell will come and do a delayed type hypersensitivity. As compared to an antibody one, right, that had a acute type 1 type hypersensitivity, or at the most type 2 and type 3, all three are antibody mediated. Okay, so that was for acute rejection. And again, pretty much the same slide we already discussed earlier, except that it's showing the acute rejection and responses. Okay, now the third type is a chronic rejection. Now you will see the difference. The first one was the antibody, second one was the T cell, and the third one is both. So you have both antibody and cell-mediated immunity. It can occur months or a year after transplantation when the tissue had served a normal function. So you thought that you transplanted a kidney and it was doing the job, everything was okay, and then you learned all of a sudden that it failed. A chronic rejection. So you can see a typical example is chronic renal transplant. And what we normally see is that these patients have progressive rise in serum creatinine. What does that suggest to you if there is a progressive rise in serum creatinine? Huh? Progressive, right? I mean, kidney function is being lost over time. So that is a kidney function test. If you remember your kidney physiology of the kidney, the most important thing was the creatinine test that we normally do to look at your. So what is creatinine? Very good. Byproduct of protein. So if you don't excrete that, you will have a high level of the byproduct of protein. And what would that do if you don't remove it? Say it again. Of course, it is already in the blood. That's why you need to filter it. But what will happen if you have high levels of creatinine?
It would not be good.
Oh, very good. Let me give a clap for this. You say it's not going to be good. Minus 5% for your next. Okay.
Yes, have excess of protein in body. That could,
Brain damage. So you have brain damage. You will become unconscious because high level of creatinine are dangerous for you. The person, if is a chronic failure, his mental functions will be gone, right? Because it damages the high level of protein byproducts are very toxic to the brain. So that's why we need to make sure that your blood is filtered so you don't accumulate that. So these cases we see vascular changes over time. Fibrosis, again, remember fibroblast, fibrosis, and you have loss of renal parenchyma, and that shows the chronic rejection that we normally see in the patients. Now, the question is that this kind of allograft rejection is coming from, of course, histocompatibility antigen that has a central role over here, and MSC, of course, is presented over here. So if you remember, the whole issue in this case is that MSC, which MSC will be important in terms of this kind of rejections? Mostly it's 2, but again, it can happen with 1 as well, okay? The difference is that sometimes some of the cells, especially for CD8, which are killer cells, they are going to be activated if you have class 1 presentation. But if you look at the map, when I taught you MSC, class 1, class 2, class 3 on HLA, and what we normally see is that the MSC genes, especially, are the one that cause major risk as compared to MSC class 1 causing minor risk. Right, so it's a gene bank. So you get 1, 2. So that's what I said, that if you give a mismatched transfusion of red blood cell, for example, and you just matched ABO group, you will get some rejection, but not that severe if you want to go and give a mismatched transfusion on rhesus, because rhesus is a protein, otherwise a polysaccharide. So you better make sure that you have a positive rhesus positive blood given to a positive patient, not a positive to a negative one, because of the protein in nature. That makes sense? So that's why, because red blood cells are having those 2 different kinds of antigen. One is a polysaccharide, and the other one is a protein. So protein is the major one that we see. The other important thing is that if you look at how the body would see that, recognize that, so you can see this is a host T cell, right? And this is a donor APC. So if you give this donor, because all the tissues will come with their cells. You cannot remove. I wish you could remove that, but you can remove the dendritic cell. So they will present the donor APC to the T cell. So T cells are going to recognize that this is a foreign peptide, and then they will react to it. So that's what we call a direct recognition in case of tissue transplant rejection. As compared to indirect recognition, what may happen in this case that the donor itself doesn't present it on its own APC, but the donor has those specific antigen called L antigen, and these L antigens are taken up by the recipient APC and presented to the host T cell. So we call indirect recognition. Pretty much the same thing. Okay, does that make sense? It depends upon who is presenting. If the donor antigen presenting cells are presenting to the recipient T cell, we call it direct. If the recipient APC are presenting to the recipient T cell, we call indirect. And this is how it happens in terms of processing to the T cells. Okay. So again, direct presentation and indirect presentation, I already gave you example for that. So if you were to compare that, there's a good table in terms of direct and indirect. So you can see this is the most likely cause for direct, and this is the most likely cause for indirect. We see that effect as acute rejection, and indirect is a tissue damage and fibrosis, and it results in a destruction of donor cell mediated by T cell. In this case, we can have a cytotoxic antibody responses as well on top of the indirect one. The reason being that your cells have processed that as a foreign antigen. Okay, so you may have, you give a choice to your own APC to present it to through AP to MSC class 1 or MSC class 2. So you may have an antibody responses in this as well. So indirect basically can also have antibody responses, whereas the direct will only have a T cell responses because of the way it is presented. And you will wonder, why is it that we care? Because one of the things that we do care is that if you want to transplant an organ, we want to make sure that because we match the tissues of the kidney, we may not match the blood type, but the blood type is also important because you cannot take all the blood out of here. So there will be something over there that may cause this, transplant rejection in terms of transfusion reaction. There is a role of T cells over here because if you say T cell mediated damage and we want to prevent that damage, so we don't want to go for immunosuppressive drugs alone. We would rather want to stop the cytokines produced by CD4 T cells. We already know what is the function of IL-2. We also know what's the function of gamma interferon, TNF-alpha, and so on and so forth. Because you can see from here that we are trying those blockers for cytokines on top of, so this is a trade-off. There was a time we used to give steroids and immunosuppressive drugs, but we had a problem because the moment we used to stop it, it gets rejected. So we would rather give cytokines blocker on top of transplantation to this patient so we can work it up and we can enhance the chances of tissue being accepted. We already discussed that. Is a repeat slide. What are the cells and what do they produce? And then again, also a repeat slide, but what it is telling you is that if there is a CD4 T cell, right, and we want to find out, we just took a tissue out and wanted to find why it got rejected. So we did a biopsy of that tissue that got rejected. And what did we do? So we had 3 different type of results. One result showed us that there are a lot of eosinophils there. So we call that eosinophilic rejection. In another report, in another organ, we call neutrophil, a lot of neutrophils there, we call neutrophil rejection. And then some of them were there for macrophage rejection. So we are learning from that. Why do we need to know that? Because each of them are specific, and we want to block activation of these cells. Why did they cause damage? Okay, so what we did was, we already know that the neutrophils were taking their cytokines from Th17, and these were the cytokines. We have to block these cytokines in this particular patient if we have to give this tissue again. If we have to block a macrophage rejection, again, these are the cytokines which are important. If we want to block the rejection for Th2 type, we have to make sure that we block IL-5. The good thing for this one is that these two, macrophage and eosinophils, can be blocked by regulatory T cells. So we can play around with TGF-beta. So that remains as a major target for these days, that if you give a TGF-beta blocker, so this is something that we are coming up in terms of avoiding immunosuppression, or very precise immunosuppression. So we can block TGF-beta. So TGF-beta will block both Th1 and Th2. If you remember, I showed you in the cytokine lecture that they were Th1 type, Th2 type, and I said the Th1 type will be opposite to Th2, and the Th2 will be opposite to Th1. But TGF-beta is important, and I also gave the example for T regulatory cells, which used to be suppressive, the new name for the regulation, so you can regulate these two. Okay, few slides for the treatment that we are doing these days. So we basically use inhibitors of lymphocyte gene expression. We have corticosteroids, we have cyclosporine, we have FK506 that we normally use. We also have, as I said earlier, as a treatment for cytokine transduction inhibitors. And I gave you an example for the most important thing was the gamma segment of the portion of the IL-2. The other name for that is CD5, CD25. So we give anti-CD25, we get rapamycin. They all basically are blockers of the cytokine signaling pathway. And we can also block the nucleotide synthesis. That normally, these drugs are basically anti-cancer drugs. The most important other symptomatic treatment is that we used to do will be immunosuppressive therapy, or we can give anti-inflammatory drugs, pretty much function to make sure that there is not overt inflammation there, okay? And the cytotoxic drugs, again, are, where would the cytotoxic drug, if I was to ask you, these are anti-metabolites, so where would the drugs act in terms of signaling pathway? Are they acting at the upstream or downstream? What do you think? Because you remember there's a receptor over there, and there's a signaling pathway. It goes through the kinase pathway, and then before it enters the nucleus, there are transcription factors. And then RNA, and then the proteins will be formed. Mostly, they are acting at a downstream level, especially for the antimetabolites, because they interfere with RNA and DNA synthesis. Okay? And I'll just stop here and take any questions.